Dear House Officers, I'm going to talk to you about chronic kidney disease, which is the most common renal disease you're going to face during your years as an intern, and what to know about it, how to educate patients about it. It will start with a quick review of chronic kidney disease and points that patients ask about and how to educate them correctly about them. So as you all know, chronic kidney disease was defined by the KDIGO in 2012. The KDIGO stands for Kidney Disease Improving Global Outcomes. It's an initiative by the International Society of Nephrology to unify the definitions and the care for patients with kidney disease. So they defined chronic kidney disease in 2012 as abnormalities of kidney structure or function present for more than 3 months with implications for health. And it is classified based on cause, GFR category, and albuminuria category, or what we call the CGA system. So chronic kidney disease is either a GFR below 60, or if there for more than 3 months, or if there is other markers of kidney damage like the presence of albuminuria, urine sediment abnormalities, electrolyte abnormalities due to tubular disorders or renal tubular disorders, abnormalities in histology, abnormalities in imaging like cysts in the kidney, or history of kidney transplantation, even if the patient has normal kidney function. But how can we explain this to patients? So we can explain that to patients that your kidneys are damaged. الكلى تعبانة، في قصور فيها. It can't filter the blood the way they should. Chronic means that the damage happened slowly and over a long period of time, and because of this, wastes build up in your body and may cause health problems. Worldwide, the chronic kidney disease is a rising disease, mainly because of a rise in its causes and its predisposing factors, with the aging of the community, increase in patients with hypertension, increase in patients with diabetes. It's also common in women and in some racial minorities, and it's expected to be the most common, the 5th common cause of death by 2040, and it is one already of the top 10 causes of death in several countries. So it is very common, and actually probably more common than we think it is, especially because we are one of the low to middle income countries, but its whole burden is not known. So patients with chronic kidney disease are always afraid of reaching end-stage kidney disease and requiring dialysis, but actually a more important point is that the presence of chronic kidney disease leads to decreased survival. So this is the survival if the patient had no chronic kidney disease, and this is the survival if they have chronic kidney disease. And it is especially independently associated with cardiovascular mortality, with increase in mortality. So up to a GFR of around 75, the mortality is close to the general population, and then it increases linearly as the GFR decreases. So patients with chronic kidney disease are more likely to die from cardiovascular disease than to progress to end-stage kidney disease, and therefore they should be treated as very high cardiovascular risk, and their cardiovascular risk should be treated, and even maybe more important than treating the progression of chronic kidney disease. When patients discover that they have elevated renal function, their first complaint or their first comment is, but I have no complaints. They think that maybe they'll have a loin pain, they'll have dysuria, they'll have change in urine, but for them there is no actual complaints that they can refer to or they can attribute to the chronic kidney disease. But actually chronic kidney disease is asymptomatic till very late. That's why there should be screening among high-risk populations, because there will be no hints that they have started having chronic kidney disease. And overall, prevention is better than cure, and in patients with high risk, they should all be counseled on how to prevent chronic kidney disease. The World Kidney Day by the ASN, they have set 8 golden rules for healthy kidneys. First, to keep fit and active, to keep regular control of your blood sugar. So if you're diabetic, you should control it, monitor your blood pressure and control it, eat healthy and keep your weight in check, maintain healthy fluid intake, which we're going to discuss later, do not smoke, do not take over-the-counter pills on a regular basis, and for us especially important is non-steroidal anti-inflammatory drugs, but other medications, if they're not indicated, they should not be taken, also supplements and herbals, and get your kidney function checked if you have one or more of the high risk factors, and this may be very, very also important in patients who are elderly or who have one of the diseases that predispose to chronic kidney disease. So risk factor conditions are many, and they may include hypertension, diabetes, cardiovascular disease, patients with previous episodes of AKI and hospitalization, patients with a family history of kidney disease, obesity, other high-risk comorbidities like lupus, patients with environmental exposure to nephrotoxins, patients on nephrotoxic drugs, patients with genetic factors that predispose, patients with previous preeclampsia, and actually patients who at birth had low birth weight. They have usually lower nephron mass than normal and actually should be followed up for renal function. So our first step should be to identify adults at risk for chronic kidney disease and to test for the most common markers are estimated GFR and albumin-creatinine ratio. There may be other markers of kidney damage. For example, in patients with lupus, we also have to do urine analysis. In patients with a family history of polycystic kidney disease, we may also do yearly or biannually an ultrasound. So based on the underlying risk, we may choose to also monitor other markers of kidney damage. But the gold standard is in every patient with any of these conditions to monitor the GFR and albumin-creatinine ratio. If we detect in one of these follow-ups that the GFR is below 60 or that the albumin-creatinine ratio is above 30, or if there are other markers of kidney damage, then we should first exclude AKI, and if AKI is present, did the patient have a recent illness? Did he take any nephrotoxic medications recently? Was he dehydrated for a while in the past month? Does he have any pyuria, any hematuria? And if this is present, then we should treat it as such. If the GFR is normal, the albumin-creatinine ratio is normal, CKD is not present, and we can retest. Now the diabetes community have their own guidelines that we should retest annually, and we usually recommend that patients also with other high risk factors should be tested annually also, but there is no guidelines in other medication, in other conditions, and we may prolong this duration if the patient is stable, or we may shorten it if there is previous illnesses that may predispose to higher or more rapid progression. So the timing usually is 1 year, but it can be longer or shorter based on the patient. But if we repeat the test and the test is still GFR below 60 and more than 30 within 3 months, and there is also evidence for chronicity, then we should treat this patient as chronic kidney disease, start staging the patient as GFR and albumin-creatinine ratio, maybe consider measuring also GFR corrected by cystatin C, and establish the underlying cause and estimate the risk of progression and initiate treatment. So staging, as we said, is classically by the GFR, the estimated GFR based on creatinine, but actually there is a growing role for cystatin C, which is another marker that can be combined. There are some pitfalls for creatinine, some pitfalls for cystatin C, and they found that the best is to use them together. So maybe we can use it once in the beginning, and maybe then follow up the patients after that by only creatinine, but it's recommended that we use it. When is cystatin C more reflective of the kidney function? If the patient has very high muscle bulk, because creatinine is secreted by muscle bulk, so a bodybuilder may have normal kidney function but have a creatinine of 1.4 or 1.5, and also in patients with very low muscle bulk, they will have lower creatinine than normal, and maybe a creatinine of 0.9 means that they have already lost some kidney function. So in patients with body habitus and changes in muscle mass, patients who are smokers, patients on low or high protein diets, patients on vegetarian diet or keto diets, patients with some illnesses like malnutrition, cancer, heart failure, cirrhosis, muscle wasting, patients with some medications that alter muscle like the steroids and anabolics, whether anabolic steroid or corticosteroids that cause catabolism, patients with medications that decrease tubular secretion, it is recommended in these groups to also measure cystatin C, and actually combining both creatinine and cystatin C in the formula for GFR is very beneficial, and it gives better results, and this result is more in line with the long-term outcomes. So why not just rely on creatinine, and why do we have to calculate the estimated GFR? Now, if we use just the creatinine and we use the most accepted formula, which is the CKD EPI 2021 formula, which is present on many medical calculators that you may find on apps, on mobile apps, or you can find it online. And you put only the age of the patient, the gender of the patient, and the creatinine of the patient, and it gives you the estimated GFR. To illustrate this, I have presented you with two examples. Patients who have a creatinine of 1.3 and patients who have a creatinine of 4.5. If this patient with a creatinine of 1.3 was a male who's 4 years old, he will have a normal GFR of 78.7 milliliter. If it's male with 60 years, it will be closer to 60. While if it is a female with 24 years old, at a creatinine of 1.3, because females usually have smaller muscle mass, she will already have stage 3A chronic kidney disease, while a female who's 63 years old will be very close to stage 3B chronic kidney disease. At a creatinine of 4.5, this male will have CKD4, while all the others will have already CKD5. So this illustrates how GFR, because it takes gender and age into considerations, may be very different and may shed a lot of light in comparison to creatinine alone. So what do we do with the estimated GFR and the albuminuria? We place the patient on the chronic kidney disease heat map. The heat map is based on albuminuria categories and GFR categories, and based on each patient on his albuminuria and his GFR, we place him in one of these boxes, and as albuminuria increases and as GFR decreases, there is increasing risk, and their combination is also associated with risk. Risk of what? Risk of progression of chronic kidney disease, of mortality, and of cardiovascular disease increases diagonally as albuminuria increases and as GFR decreases. This heat map can also be used to monitor in the frequency of monitoring of patients in the decision making. So patients with A1 or normal to mildly increased albuminuria and GFR of G1 or G2 category, they are green because they have low risk. Their risk is equal to the general population, and they can only be, they don't need to take any treatment, and they can be screened once per year. While others, it is different. You start treating any patient with an albuminuria that is above A2 or is above 30 milligram per gram, and GFR that is below 60, he needs to be treated as a CKD patient, and the frequency of monitoring increases as the GFR decreases and as the albuminuria increases. So patients may also ask, does kidney disease have any symptoms? Should I be aware of any symptoms? Symptoms are actually only present in later stages of kidney disease. He may complain of feeling tired or short of breath because of the anemia. He may have trouble thinking clearly because of the uremic effect on the cognition. He may not feel like eating. He may have anorexia. He may have trouble sleeping. He may have dry, itchy skin. He may have muscle cramps at night because of the altering in the electrolytes, and also because of the uremic toxins. There is frequently polyuria, so the patient may complain of going to the bathroom more often, especially at night. He may have swollen feet and ankles. He may have puffiness around the eye, especially in the morning. All these are signs of kidney disease, but they usually are present late. Patients also ask, how can CKD affect my day-to-day life? Patients are usually afraid that all kidney disease may lead to dialysis, but actually, although it is progressive, many patients may not progress to end-stage kidney disease and need dialysis. They can continue to live a productive life. It does not stop them from any activity as tolerated by their general condition. They should actually stay physically active and not limit their activity if they can tolerate it. But they may need to change what they eat and become more healthy to keep their kidneys functioning and to keep them healthy as long as possible. The most important is that kidney disease can lead to other problems. Most commonly, we said heart disease, so it increases chances of strokes, of heart attacks, and it can also lead to hypertension or high blood pressure. And actually, there is a higher chance of developing these than to lead to chronic kidney disease, but there may be increased risk of chronic kidney disease if the patient has an episode of AKI. So we should also ask him to prevent, or part of the treatment is to prevent the occurrence of AKI on top of his chronic kidney disease. So how do we manage chronic kidney disease? Generally, the goal of treatment is to protect the kidneys from more damage, and the sooner we start, that's why we have to screen to detect it as early as possible in CKD3A or even in patients with albuminuria without an decrease in GFR. The better we can prevent it, and the better we can prolong the life of the kidney. Once the patient is in stage 5, even if we implement most of the preventive measures and the measures that delay progression is more likely to occur, and all the measures we use may not give us enough results. But also the steps we take to delay progression also reduces the cardiovascular risk. So even in patients with CKD1, it's important to reduce cardiovascular risk, identify patients at high risk. In all stages up to stage 4, an aim is to delay progression. In the patients with a GFR that starts to be in the CKD3, whether A or B, we should prevent and manage complications and look for them, promote self-management. Once patient reaches stage 4, he should be seen by a nephrologist and he should be prepared for renal replacement therapy. So in 2024, they have released the KDIGO chronic kidney disease guidelines, and they set a holistic approach to patients with chronic kidney disease. So in all patients, lifestyle intervention should be a very important part of the treatment, that the patient should eat healthy diet, mainly based on plants. Physical activity should be increased as tolerated by the patient. He should stop using any tobacco products, so whether cigarettes or vape or also shisha in Egypt. He should manage their weight if they are overweight, and we should regularly assess them every 3 to 6 months. And there are first-line therapies that most patients should be on, which are SGLT2 inhibitors or sodium glucose cotransporter 2 inhibitors, and they should be continued until dialysis or transplantation is safe, but they should not be started if the GFR is below 20, and they have cardiovascular, renal benefit, and if the patient is diabetic, they can also help in controlling his diabetes, but even if he's not diabetic, they are indicated to lower proteinuria. The second thing is to aim for a systolic blood pressure of, they set it at less than 120 millimeter mercury, but we'll talk that other guidelines prefer that we should lower the blood pressure, or the cutoff of the target blood pressure should be below 130 over 80, and that below 120 may increase the renal function. And ROS inhibitors should be part of the treatment, especially at maximally tolerated dose if the patient is hypertensive. Control of blood pressure and ROS inhibitors also is of benefit to the heart, the kidney, and also will control blood pressure. Most patients should also be on statin. whether moderate or high intensity statin to prevent the cardiovascular disease, which we said is very common. Additional therapy should be targeted based on the presence of complications. So if the patient is still hyperglycemic despite SGLT2 inhibitors, then other antidiabetics should be added. The antidiabetic with benefit to the kidney include metformin, but it cannot be given if the GFR is below 30, and the dose should be decreased if the GFR is below 45, and we should continue to monitor glucose until we reach the target hemoglobin A1C. The other anti-diabetic with benefit to the kidney are GLP-1 receptor agonists or incretin mimetics. Regarding blood pressure, we should also add treatments until we achieve the individualized blood pressure target. So second line after RAS inhibitors are either calcium channel blockers or diuretics. And if still hypertensive, we may add steroidal MRAs or mineralocorticoid receptor antagonists like spironolactone or eplerenone if the GFR is above 45. And there is also evidence for the newer non-steroidal MRA finerenone in people with diabetes, and they are trying it in people with CKD without diabetes, and it may have additional antiproteinuric and anti-progression effects. If the patient has atherosclerotic cardiovascular disease already, so he had an MI or he had a stroke, antiplatelets or aspirin can be added, but they should not be added for primary prevention. They should be added only for secondary prevention. Other treatments to control lipids may be added to ameliorate the cardiovascular disease, and we should also, in all patients, especially after reaching CKD stage 3B, monitor anemia, acidosis, chronic kidney disease-related mineral bone disease, potassium, and treat them as appropriate, because this is also part of the holistic approach to treat patients. So actually, there is no specific treatment for chronic kidney disease, but the treatment is a combination of all these factors and the regular assessment. So why are SGLT2 inhibitors and RAS inhibitors are so important? In many of the patients with chronic kidney disease, there is intraglomerular or glomerular hypertension. So there's hypertension, increased blood pressure in the glomeruli, in the glomerular blood vessels. That's why there is proteinuria, and decrease in this intraglomerular hypertension and this hemodynamic effect that is present in most cases of chronic kidney disease will ameliorate the progression of chronic kidney disease. Proteinuria is very injurious to the kidney. The reabsorption of proteinuria and its passage in the interstitium leads to more progression, and they found that all treatments that decrease proteinuria are actually very beneficial. So how does RAS blockade reduce the intraglomerular pressure? By efferent vasodilatation, while SGLT2 inhibitors cause afferent vasoconstriction. So together they decrease more effectively the blood pressure inside the kidneys. But they have their pitfalls and they have their side effects that should be monitored closely. So whenever we initiate or increase the dose of ACE inhibitor or ARBs, we should monitor serum creatinine and potassium 2 to 4 weeks after starting or changing the dose. Because of this vasodilatation of the efferent decreases the transit time inside the glomerulus and may cause glomerular ischemia if the blood reaching the kidney is already low. And also RAS blockers, they eventually block aldosterone, and aldosterone is responsible for excretion of potassium. So once it is blocked, there may be hyperkalemia. So that's why we monitor creatinine and we monitor potassium. If after 2 to 4 weeks there is normokalemia and there is no or an increase in creatinine that is less than 30% from baseline, we can continue ACE or ARBs or even try to increase the dose with repeated monitoring. But if there is hyperkalemia, we should review concurrent drugs that cause hyperkalemia, decrease potassium intake in diet, consider adding diuretics, sodium bicarbonate, and cation exchanges that decrease potassium absorption. And if still the patient is hyperkalemic, we should reduce the dose or stop it altogether. Also, if there is an increase in creatinine by more than 30%, we should review other causes of AKI, correct any volume depletion, Review blood pressure medications, and if the patient has become hypotensive, reduce other antihypertensives that have no benefit to the kidney. Reassess concomitant medication, so if he's on diuretics, especially potassium-sparing diuretics or non-steroidals, consider that the patient may have renal artery stenosis, and again, if still there is an increase, then we should stop or reduce the dose of ACE inhibitors or ARBs. We should also monitor that there are other side effects. For example, there is very commonly about 30% to 40% of patients that ACE inhibitors may cause a dry cough. Some patients describe it as a shar'a, and it can happen it's actually frequent, and it stops by when we switch ACE inhibitors to ARBs. So we should ask about it after initiation of ACE inhibitors. There are some patients that also get angioneurotic edema after ACE inhibitors, and they should be switched to ARBs. Metabolic acidosis can occur by the same mechanism of hyperkalemia. There may be some anemia. ACE and ARBs are contraindicated in pregnancy, so if this is a young female, we should stop ACE and ARBs before she becomes pregnant and replace it with other medications. And it can, if the patient develops dehydration or hypotension, lead to AKI. So there is something called the sick day rule. If a patient develops a dehydrating illness, he should stop the ACE and ARBs, also diuretics, also SGLT2 inhibitors, until he is able to drink again and he becomes stable. As we said, the KDIGO recommends an aggressive target, that the blood pressure should be below 120 millimeter mercury, but this is also based on standardized blood pressure measurement, which means that we should measure the blood pressure in a dark room when the patient alone by an automated device, an automated validated device, so not in the usual office environment. So the European Society of Hypertension and also the International Society of Hypertension recommend that the target, even in patients with chronic kidney disease, should in patients with between 18 and 64 be less than 130 over 80 millimeter mercury, and in patients over 65 it should be below 140 over 80. But the most important thing is as tolerated by the patient. So if the patient is overall healthy and can tolerate lower blood pressure, this is better for the kidney. But if the patient starts to complain of dizziness or falling or any other complaints, then we should elevate the blood pressure. And they say actually set a lower limit, so below 120 in most patients would be too low, and below 70 in most patients would be too low. But again, we should tailor it according to the tolerance of the patient. Yes, the lower is better, but without any adverse effects. In diabetes, there is also the guidelines that the joint guidelines between the ADA, or the American Diabetes Association, and the KDIGO, and they said also that comprehensive care, lifestyle intervention, and they said that the optimal antihyperglycemic therapies in patients with type 2 diabetes are metformin plus SGLT2 inhibitors, but metformin, we lower the dose to half the dose, to maximally 1,000 milligram if the GFR is below 40, and we stop it if the patient's GFR is below 30 and start other treatments. SGLT2 inhibitors can be initiated. We'd say that the newer guidelines do not initiate if GFR below 20, and this may change in the future, and if the patient starts dialysis, they should be discontinued. So like we said, how to safely prescribe ACE and ARBs, there is also some guidelines on how to prescribe SGLT2 inhibitors safely, because also they cause afferent vasoconstriction, so they may cause also some AKI and some dehydration in some patients, because they are also diuretic, and because they are hypoglycemic, there is some risk on glycemia. So first, patient selection, patients especially who are high priority, first the GFR should be above 20, but sometimes we give it below 20 if there is foreseen benefit, again, if the patient has heart failure or there is a very high albumin-creatinine ratio, but the guidelines still state that the GFR should be more than 20 to start SGLT2 inhibitor. Potential contraindications are present, so patients with frequent genital infections or UTI may not be good candidates because the hyperglycemia may increase the risk of UTI. Patients with frequent diabetic ketoacidosis because it can cause euglycemic ketoacidosis. Patients with foot ulcers were excluded because of some cases of foot ulcers with canagliflozin, but there has been no reports with dapagliflozin and empagliflozin, so this is again relative. One of the potential contraindications was immunosuppression, but now it is being increasingly used in patients with transplantation and in patients with glomerular diseases. So again, this contraindication is relative and has been changed. In patients with type 1 diabetics, it's preferred not to use because, again, they are at increased risk for euglycemic diabetic ketoacidosis. As we said, in transplantation, there are newer evidence that they have been used successfully in transplant patients and they decrease the progression of chronic kidney disease in these patients. In autosomal dominant polycystic kidney disease, there is still no evidence to suggest that it is beneficial. Actually, some studies have found that it decreases progression, but other studies have found that it increases the size of the cysts. So there is a call for more trials on it to know whether it is overall beneficial or risky. In patients who are catheterized, again, it may increase the risk of urinary tract infection, but again, these are all relative rather than absolute contraindications. What is nephroprotective dose? In dapagliflozin it is 10 milligram, and in empagliflozin it is also 10 milligram. We should educate the patient to take care of their feet and to monitor for any foot ulcers. The sick day protocol should be part of the education. So again, if you are sick and dehydrated, maybe you should skip the SGLT2 inhibitors for 1 or 2 days during this sickness. And also, some recommend that it is stopped before any operation because during this part, the patient is not drinking enough and he may become dehydrated. Is there any hypoglycemia risk? It's more in patients on insulin or sulfonylurea if their hemoglobin A1C is at or below goal. So in these patients, we may consider decreasing the dose of insulin or sulfonylurea before starting the SGLT2 inhibitor, but alone it is not hypoglycemic, and as we said, we give it in patients with CKD without diabetes. And if the patient also has frequently hypoglycemic symptoms, we should reduce their doses and monitor for hypoglycemia. We should also assess the volume before prescribing SGLT2 inhibitors. If the patient is using diuretics, if he is dry, if he had a history of AKI, we could recommend decreasing the dose of diuretic before giving it. Ask the patient to drink enough fluid, not too much, not too little, and reassess the volume after prescription. Now, the addition of SGLT2 inhibitors to ROS inhibitors has improved the potential for progression of chronic kidney disease. So if we take an example of patient, and these are all projections, actually SGLT2 inhibitors are relatively new drugs. They have only been in the market since 2013, so they have not passed 20 years or 25 years and as in this, but this is projected based on the GFR decline after giving these treatments, that untreated, a patient with diabetes and chronic kidney disease who has a GFR is 60 will have a reduction in GFR by 12 milliliter per year and will reach end-stage renal disease by 5 years after decline of the GFR below 60. With ROS inhibitors, there is a slower decline to about 4.6 milliliter per minute, so that the same patient will end in end-stage renal disease after 10 years, while if we use both ROS inhibitors and SGLT2 inhibitors, this decline drops to 2 milliliter per minute per year, which gives the projection that he will not reach end-stage kidney disease except after 25 years. So it has prolonged significantly the life or the life expectancy of the graft. Beside optimal blood pressure and glycemic control, also we should prevent AKI. So we should educate the patients about maintaining euvolemia and normal blood pressure. Most patients should have a manometer at home and should monitor their blood pressure, especially during acute illness. They should maintain euvolemia and drink enough water. They should avoid nephrotoxins, so we should educate all patients that they should not be taking any strong anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, and if they have pain or fever, they should stick to paracetamol, which is safer to the kidney. There should be precautions before contrast. Any patients with chronic kidney disease, we have to avoid contrast if possible and to use it with caution if the GFR is 30. Avoid urinary tract infection and obstruction. So if the patient gets frequent UTIs or frequent urinary tract obstruction, we should look for the cause and correct it. And the medicine sick guidance rule. Patients, or we said, should also adopt all the primary preventions for cardiovascular disease. And if we review them, we'll find that they are very similar to the prevention of chronic kidney disease. So if the patient has high blood pressure, it should be below 130. They should maintain physical activity. Aspirin for primary prevention is now only for high-risk selected patients. We said it's more accepted in secondary prevention. If patient is type 2 diabetics, they should control their diabetes. They should eat a healthy diet. They should refrain from tobacco use, and they should treat their cholesterol. Lifestyle is very important. The physical activity is a very important part, and it should be compatible to the patient's health, tolerance, and level of frailty. But we usually recommend that there is moderate intensity physical activity like brisk walking for 150 minutes per week that can be divided to 30 minutes 5 days. And overall, they found that avoiding sedentary behavior is very important. So even in patients who do not reach the 30-minute walking, they found that patients with jobs on desks, they have increased risk for cardiovascular disease. And to take snacktivity or snacks of activity every 30 minutes, which with a 2-minute walk, this actually reduces their cardiovascular risk significantly. Achieving an optimal BMI, healthy eating habits, not using tobacco, and actually a common overseen aspect is adequate sleep and treating sleep apnea, including sleeping during the natural circadian rhythm. So 8 hours sleep, especially at night, is very also important in controlling blood pressure, in controlling hyperglycemia, and in maintaining a healthy CKD. So actually the majority of patients do not follow this. So actually smoking is the most commonly or abided by recommendation. Many patients, when they know that they have CKD, when they know that they have diabetes, they have increased cardiovascular risk, stop smoking. But actually maintaining healthy weight, performing the recommended physical activity, eating a healthy diet is more difficult to a patient. And eating right in chronic kidney disease is more complicated. We should choose and prepare food with less salt and sodium in most cases. The patients should be recommended to eat the right amount of protein. They should choose food that is healthy for their heart. They choose food that and drinks that contain less phosphorus because they can have hyperphosphatemia, and they should choose food with the right amount of potassium. So there are a lot of guidelines regarding nutrition in chronic kidney disease, and also they should take adequate caloric intake, or their proteins will be converted into sugar, and they will not benefit from it. So actually prescribing a healthy diet in chronic kidney disease is a bit more difficult than in diabetics or in hypertensive. We're going to talk about some of these rules. So for example, there are we tell the patient don't eat salt, but actually we should recommend or give more precise recommendations to buy fresh foods and cook at home with less salt. Avoid food with high sodium, including processed meats, including pickles or مخلل, including salty fish, الفسيخ والرنجة, including cheeses with a lot of salt like الجبن الحادقة in general. and choose fresh meat, poultry, eggs, and plant proteins instead, to keep to minimize prepared foods like fast food, to minimize salty sauces, to minimize eating in restaurants, and to also use other spices like sour, bitter, and spicy if they can tolerate it as alternatives to salt. Eating the right amount and right types of protein is also controversial. Should we restrict proteins? Actually, the newer guidelines said that we should not restrict it in most patients below 0.8. And plant-based proteins, there has been a misinformation that plant proteins are incomplete proteins and that they should be avoided in patients with chronic kidney disease and hyperuricemia. But actually, new evidence supports that we give more plant-based sources and that they recommend a plant-dominant low-protein diet because it's higher in fibers and actually the phosphate in it is not absorbable, the uric acid in it is not absorbable. The potassium in it may be a problem for some patients, but actually overall it is healthier than animal proteins. So actually you should not tell patients, and even the lack of essential amino acids in some of these plant-based proteins is ameliorated by eating multiple sources or different sources of plant-based proteins that can make it a more complete protein. So the KDIGO recommend that we maintain a protein intake of 0.8 gram per kilogram and should not be restricted, especially in patients with sarcopenia or low muscle mass, in patients with cachexia, or in patients at high risk for undernutrition. But we should avoid high protein intake of more than 1.3 gram per kilogram per day. Patients who are bodybuilding or doctors who are bodybuilding, they actually eat more than 2 to 2.5 gram per kilogram per day, and this can cause secondary focal segmental in some patients. So whenever someone is eating too high protein or for bodybuilding, I recommend actually that also they monitor their renal function. So do keto analogs and keto amino acids and also essential amino acids that are present in the market, and they are marketed as a treatment for chronic kidney disease. They are actually only indicated in combination with a low protein diet or a very low protein diet. So in patients with a very low protein diet, that should be prescribed by a nutritionist, and they should be followed up closely by a nutritionist of 0.3 to 0.4 gram per kilogram per day. They can be supplemented with essential or keto acid analogs to reach, together with the protein diet, 0.6 gram per kilogram body weight. But their prescription in all patients with chronic kidney disease at low doses that do not reach the recommended amount, and without monitoring of their whole protein intake, and without monitoring of their muscle mass and prevention of them having sarcopenia, is actually not correct. Heart healthy foods include low-fat diet with healthy fats, so maybe avoid frying, avoid cooking in too much fat. We usually tell patients بلاش المقلي والمسبك، الأكل يبقى ني في ني. So cooking with a minimal amount of fats, preferably high healthier fats like olive oil, to remove fat from meat and poultry and skin from poultry, to prefer to the white meats, the poultry, the fish, the rabbits, the low or free fat milk and yogurt and cheese. Lean cuts of meat should be better. Grill, broil, bake, roast, or stir fry food instead of deep frying, and increase fruits and vegetables. The Mediterranean diet for many years is the healthiest diet for heart healthy diet, and actually the wine in moderation, in more recent studies, they found that they had said before that alcohol in moderation is also beneficial to the heart and is part of the Mediterranean diet. But actually more recent studies say that alcohol in any amount is unhealthy, so they have removed the wine and the alcohol from the Mediterranean diet. So eating a Mediterranean diet is beneficial, but I think it's more difficult to prescribe it to patients. Another option to easily prescribe to patients how to eat healthy is the healthy plate diet, which is that half the plate in each meal should be fruits and vegetables, and the other half should be 1/4 of it whole grains and 1/4 of it healthy proteins, to drink enough water and to use healthy oils. Now, the problem with chronic kidney disease is that in the advanced stages, we have to monitor potassium and intake and to monitor phosphorus intake. And this may entail some avoiding of some of the food that we have already prescribed. So some fish are low in phosphorus, so we say fish that are don't have dark meats are better. Poultry is present, rabbits are present, but they are actually they have and also milk, it has some phosphorus, so in these cases they should reduce it. Sometimes boiling these meats can reduce the phosphorus content, but usually legumes and plant proteins have lower phosphorus content. Egg whites have low phosphorus content, while egg yolks are high in phosphorus content. Hard cheeses and nuts are high in phosphorus contents. Processed foods and soft drinks, even diet soft drinks, are very high in phosphorus, and they should and we should recommend that patients avoid them. But the healthiest proteins are the egg whites, fruits and vegetables, and legumes are the best protein sources. Eating the right amount of potassium also is important. It depends on potassium. Most will need reduction in the potassium content. And again, if we are using canned foods, they should be drained, and we should rather use fresh foods. Boil vegetables and discard water so boiling of the meats that contain phosphorus can reduce the phosphorus content, and boiling vegetables, so we say half boil them and then cook them the way you want, will reduce the potassium contents. And it's very important to recommend against using the salt substitutes. So some patients with hypertension, they go to the pharmacist and they take the salt substitute or the salt-free the sodium-free salt, but actually these sodium-free salts are potassium salts, so they should be recommended against. And actually the list of fruits and vegetables that include high potassium is very long, but we should educate patients also about the lower potassium food that they can eat in abundance, and the high potassium foods that they should avoid. If there is hyperkalemia, part of its treatment is optimizing serum bicarbonate, optimizing glycemic control. We can add loop diuretics and SGLT2 inhibitors. They reduce potassium. Second line would be dietary restriction, but actually this needs the patient to be very aware, and is actually better done in combination with a dietitian. And if a third line is stopping medications that increase potassium, although we know that some of them are beneficial, and to prescribe exchange resins to lower potassium. And although we are afraid of plant-based foods, actually the absorption rate of potassium in plant-based foods is lower than that in animal-based foods and in processed foods. So again, plants are not as unhealthy as animal-based proteins in patients with chronic kidney disease. Treating metabolic acidosis is very important, and actually part of this treatment is increasing salt, increasing fruits and vegetables, because fruits and vegetables are base producing once they are broken down, and actually proteins are acid producing. And if the patient has severe acidosis with a bicarbonate of below 16, he should be given bicarbonate to correct this acidosis, and we should monitor the correct dose. Again, in hyperuricemia, actually, it is not recommended to start treatment just based on the uric acid and non-pharmacological treatment. Again, although patients think that eating too much fava beans or fool will cause hyperuricemia, actually plant proteins are safe, and organ proteins, beverages which are sweetened, and alcohol, smoking, excess body weight, and high protein diet are actually, these are the things that should be avoided to reduce hyperuricemia. So how much water should the patient drink, and should the patient drink, some patients say that they drink 3 or 4 liters of water per day. Actually, it's a myth. We should drink enough water based on thirst in most of us, maintain euvolemia. We prescribe giving higher water intake, so 3 to 4 liters per day, or aiming for a 3 to 4 liters urine output per day in patients with recurrent stones and in patients with autosomal polycystic kidney disease, but there's no evidence for the benefit of increasing the water intake in other patients. There is no clear benefit on reducing chronic kidney disease, cardiovascular, and all-cause mortality. And actually, in some studies, they found that water intake above 1.5 liter per day in patients with chronic kidney disease may be associated with more rapid progression of chronic kidney disease than maintaining the water intake between 1 and 1.5 liters per day. And actually, in patients with advanced chronic kidney disease and in patients on high-dose diuretics, it is recommended that we tell them not to increase the water intake above 1 liter per day, or else they will have hyponatremia because their kidney is not able to maintain normal potassium. Now, as we are in the era of global warming, it is very important also to give tips for patients during extreme heat to stay hydrated. Maybe in these cases increase their water intake based on the heat, based on their exposure to the heat. Above this, avoid alcoholic drinks, soft drinks, too much sugar, tea and coffee, because they are dehydrating. Stay cool, so avoid staying in the sun for too long. Wear cotton and linen clothes and take showers frequently. Use sun protection, limit activity, look for shade and eating light during this, avoiding sugary food that can worsen dehydration, and watch for signs of heat stroke. So if the patient develops fatigue, vomiting, cramping, he should go to the emergency department, because patients with chronic kidney disease are at a higher risk for dehydration and heat strokes. About fasting for Ramadan, actually the British Islamic Medical Association have a Ramadan compendium that is updated yearly. It's created by some doctors and together with some fuqaha, and they it's not just for chronic kidney disease. They have set guidelines for multiple of the chronic illnesses, and they divide patients into very high risk that we should advise them that they must not fast. And actually some fuqaha may say that they may take they do ithm by fasting if there is very high risk for their health, and there is high risk patients that they should recommend that they should not fast, and there are low to moderate risk, and we should recommend that they fast safely with follow-up. And patients actually in stage 3 are in the group that should not fast. Patients in stage 4 to 5 and patients on dialysis, patients with pregnancy, patients who are transplant, they fall in these categories. But overall, if the patient insists to fast, we should measure creatinine after 5 days of fasting in Ramadan, and if it increases because of fasting, we should recommend that the patient stops fasting. So it's also very important when treating comorbid conditions to put GFR into consideration and prescribe drugs, adjust doses accordingly, avoid nephrotoxic drugs, and maybe resort to clinical pharmacists, or to always review the drugs that the patient is taking. There are a lot of drugs that are nephrotoxic, and we should always try to avoid them and use the less or the non-nephrotoxic drugs. We should also always review what herbals the patient is taking, and there are a lot of herbals worldwide that have been associated with nephrotoxicity, and overall, because many of the herbs the patients take from al-attar, they are not very well studied, and we do not know all the constituents in them. We should actually recommend against using any herbals in his medication. And we always should review the medications, try to minimize them, and to optimize the medication impact and try to avoid nephrotoxic drugs. Sick day rule implementation is very important. Again, as we said, identify the dehydrating illness if present, stop the pills that cause rehydrating or that may cause AKI in these cases, and once the patient recovers, we resume these medications. We can also be done before elective surgery, but we should always remember to restart them. These are the main groups that may be temporarily discontinued before elective surgeries and before any illness like ACE and ARBs, diuretics, SGLT2 inhibitors, non-steroidals, and aminoglycosides. Regarding imaging, again, if patient is high risk with a GFR of 30 or GFR 30 to 45 with additional risk factors, we should prefer to do other modalities than contrast-enhanced radiology. But if it is very important, then we hold diuretics, nephrotoxic drugs, we give the patient prophylactic isotonic saline, we give the lowest necessary dose of iodinated contrast media, and to avoid it. What about MRI? There were some guides that said that, or some literature that said that gadolinium may cause nephrogenic systemic fibrosis in some patients with chronic kidney disease, but actually the newer gadolinium-based agents are safe and can be used safely. When do we refer patients to nephrologists? Depending on the cause. So if the cause of chronic kidney disease is uncertain, or if it is hereditary, or if there is recurrent extensive nephrolithiasis, based on GFR, if the GFR is below 30 or it's rapidly decreasing, the GFR is decreasing, and the patient is expected to develop end-stage kidney disease frequently or need renal replacement therapy frequently. Albuminuria and microscopic hematuria, if they are present, for further follow-up of the patient for diagnosis of any glomerulonephritis, they should be referred to nephrologists. And others, if the patient has chronic kidney disease complications like hypertension refractory to treatment, hyperkalemia, anemia, CKD, MBD, they should also be referred to nephrologists. Patients with stages 4 and 5 start having symptoms that or uremic symptoms that are multiple, and that should actually be addressed and should be treated to improve or ameliorate their effects on his life. Once the patient reaches stage 5 or even late stage 4, he should be educated that you have neared or you have reached a stage of kidney failure. الكلى يعني خلاص مش شغالة, you know they no longer work well enough to keep you alive, and you need kidney replacement therapy. There is no cure for kidney failure, but there are treatments to replace the work of the failed kidney. That's how we explain انت الكلى خلاص باظت, بس في الحمد لله يعني طريقة ان احنا نعوض وظيفة الكلى. There are other organs that if they fail there is no treatment, but in kidneys there is renal replacement therapy, and there are two treatments for renal failure, which are dialysis and kidney transplantation. Of course, kidney transplantation is preferred, and but in Egypt it's only allowed from related donor who is completely healthy, and he will be screened, and it is a better option, but it's not available for everybody based on the availability of a relative who is healthy and willing to give him the kidney. Dialysis is another option, either in the form of hemodialysis or peritoneal dialysis, but most commonly we use hemodialysis. And once the patient nears this stage, we should educate him if he can or if he's willing to do a transplant and can do it. This is a better option, and we refer him to the transplant clinic. We do transplants here and there is a transplant clinic every Sunday and Wednesday. Or if he's not a candidate, or if he has no available donor, then we should prepare him for dialysis. It's normal to fear beginning treatment, but actually there are patients who have been on dialysis for more than 40 years. This is the Guinness World Record holder for the longest duration on dialysis, but it is normal to have concerns, and he may be more comfortable if he visits the dialysis unit, if he talks to other patients with renal failure. Again, if the transplantation is an option, we should refer patient to transplant centers before he reaches end-stage renal disease. The timing of initiation of dialysis, it used to be every patient with stage 5 below GFR below 15 should start dialysis, but actually they found that early initiation is associated with more mortality and morbidity. So it is based on both lab and on clinical features. So if the patient has one or more of these situations, symptoms attributable to kidney failure, like neurological signs and symptoms, pericarditis, anorexia, medically resistant acid-base or electrolyte abnormalities, intractable pruritus, cirrhosis, acid-base or electrolyte abnormalities, inability to control volume, status, or blood pressure, progressive deterioration in nutritional status or cognitive impairment, then the patient should start dialysis. It usually starts at a GFR of below 5 to 10 milliliter, and there is incremental dialysis where we start with 1 weekly session or 1 session every 10 days, and then increase the frequency as the GFR declines further. But kidney transplantation can be started preemptively when the GFR is below 20. So again, stage 4, if the patient is willing and has a potential donor, he may be referred to the transplant clinic. So when do we refer? If there is progressive chronic kidney disease and it is the risk of kidney failure is more than 10 to 20% within the next year. And again, we should educate the patient about the options and prepare for the chosen modality. In most patients, we should create the AV fistula before the patient needs dialysis, although some patients refuse this. But it is better because, as you know, the AV fistula takes 4 to 8 weeks to maturate, and some fistulas do not work, so the patient, after waiting 4 to 8 weeks, the fistula may not work and he may need to create another fistula so that we cannulate that and perform the dialysis. So we should also, patients with advanced CKD should know when they should visit the emergency department if they have shortness of breath, if they have decreased urine output or anuria, if they feel they are confused or the family members feel they are confused, if they have persistent anorexia, nausea, vomiting, if they have disturbed sleep, if they have persistent itching, if they have palpitations, or if they have chest pain. Now, as we said, this is my concluding remarks. Prevention is the best cure. Early detection means that we start treatment early, and in early stages, treatment is more effective. Retarding progression and decreasing cardiovascular illness should be our aim. So retarding progression is done by RAS blockers and SGLT2 inhibitors, but it's not appropriate for all patients, and no treatment can reverse chronic kidney disease. Reducing cardiovascular risk is very important aim of treatment, and non-traditional risk factors are still a problem. Thank you very much, doctors, and I wish you all the best in your career as physicians. Thank you.